So we're going to get started, but before we do that, we'd like to respectfully acknowledge that RESCON's office is located in the territory and Treaty 13 lands of the Mississaugas of the Credit First Nation. We also recognize the traditional territory of the Huron-Wendat and the Haudenosaunee. Pick it back to you, Andrew.
Thanks, Mina. And so I have the pleasure of giving the opening remarks. And so as always, we shall start by thanking our partners. And so the first partner is obviously the Ministry of Labor, and we're delighted to have the Chief Prevention Office here. We're also delighted to meet the new Chief Prevention Officer, and I won't ruin that introduction. I'd also like to thank the groups that we continue to partner with. This is our 6th event, and so we need to recognize ORCA, OHBA, BUILD, OGCA, OSWCA, so Sewer and Water Main, Heavy, and ORBA, which is roads. So this is our 6th event, and I think in June when we did our 5th, we thought it would be over, right? We thought if everyone got vaccinated in the summer, we'd be done. I guess that's not true. And while we kind of set the target back then at 80%, that was a great target. But now we know we need to do better. And so what has changed since our last meeting in June? Well, we know that the vaccines work and they work really well. And so to highlight that, I think the favorite stat that I've seen is you're 42 times less likely to be admitted to the ICU if you're double vaccinated. So that's pretty simple. They really do work. The problem is you can still get COVID and you can still transmit it, even if you have a vaccination or 2 vaccinations. But what we also know is when you look at Ontario compared to other jurisdictions, we're doing a lot better with the 4th wave. And you look at the southern states, or what some people call Florida North, which is Alberta, they're not doing so well, and it's because they don't have the vaccination rates that we do, and they don't adhere to PPE, whether in the job sites, in the workplaces, or even in public. So you'll hear a consistent message that PPE needs to continue. What we've also done really well, and not to keep dumping in Alberta, is we've looked at and we've continued to collect data. With that in mind, all of the associations that we're working with have launched a survey, and Ahid's going to put that in the chat. You guys are going to see this survey early and often and consistently until we get about 1,000 people to fill it out. Right now, we're very close to 700, and so thank you to everyone who's filled it out and has shared it with your network. But we do want 1,000 because that is a statistically very nice number. And so please, we know the whole day, especially when I'm speaking, is not that exciting. So you could fill out the survey right now. It's in the chat. You could also send it to your network right now. I will not be offended. Going through this, today's focus is all about vaccines and vaccinations. We're going to get an update, as we said, from the Chief Prevention Officer. Mike Sherrard's going to join us for another legal update. And really, we're going to look at vaccination policies, what your choices are and what your legal liabilities are. And then we're going to be joined by Dr. Eddie Wasser. And we've selected this speaker because the early results from the survey has highlighted why people may be vaccine hesitant. And so specifically, we've asked him to deal with these issues. And specifically, we've asked him to talk to HR, health and safety, and business professionals and owners when they're talking to their workers, encouraging them to get vaccinated. But with that, I will give it back to Mina, who is going to introduce Bill and Joel.
Thanks, Andrew. Our first 2 speakers are former acting Chief Prevention Officer Bill Roy and current Chief Prevention Officer Joel Moody. Bill Roy is currently the Director of the Strategy and Integration Branch of the Prevention Office at the Ministry of Labor, Training and Skills Development. Bill Roy joined the ministry in 2004 as a construction health and safety inspector in Toronto, holding several positions in operations division, including regional program coordinator, provincial specialist, and most recently, program manager. Bill has been very involved in prevention programs and was part of the secretariat that led the committees that developed the new mandatory training programs and the Working at Height standard, as well as the development of the training and training provider standard development. Prior to joining the MOL, Bill worked in heavy civil construction with Dufferin Construction, and he also held roles in the quality control department and eventually became a project engineer. Dr. Joel Moody joins the ministry from the Electrical Safety Authority, where he held the role of Chief Public Safety Officer and Senior Director Analytics. He is a seasoned public health and occupational health and safety leader with over 17 years experience working in various labor organizations throughout the province of Ontario. As a member of ESA's senior leadership team, Joel led its future strategic direction to achieve its Getting to Zero vision of safety in Ontario. He led numerous high-profile projects, which included developing strategies and tactics to combat electrical fires in high-rise occupancy residential structures impacting over 600 dwellings in Toronto, resulting in City Council changes to bylaws. He has championed innovative approaches to harm reduction and regulatory oversight and made equity, diversity, and inclusion central to his philosophy of leadership. Furthermore, his ability to build and maintain strong relationships with stakeholders, as well as his passion for worker health and safety, is well known throughout the health and safety sector. Please join me in welcoming Bill Roy and Joel Moody.
Thank you very much. It sounds like you got our non-short bios. So I'll pass it over to you, sir.
Bill, thank you. Mina, Andrew, thank you so much for such a great and warm welcome. It's my pleasure to really join the COVID-19 vaccine policy and promotion event today. As I'm transitioning into my new role as the CPO, I've heard about all the great and wonderful work that RESCON has done to really put health and safety first. It's your collaboration with my predecessor, province's antigen screening program really displays your commitment to doing whatever is needed to support our workplaces during this challenging time. And so for me, the collaboration between RESCON and the ministry, particularly my office at the Prevention Division, is something that we value very much in that relationship. So looking forward to working together. Thank you very much. Bill?
Joel, you broke up just a little bit at the start. Could you just repeat the first probably 3-4 sentences?
Oh, sure, most definitely. Really just wanted to say thank you to Andrew and Mina. As I said, it's really a pleasure to join the COVID-19 vaccine policy and promotion event today. I was just saying, as I transition into this new role, the partnerships that RESCON has had with my predecessor, and as well as all the work that you've done with the antigens, the screening test and being leaders in the sector. I cannot say how much that's very important as we continue to move through this pandemic together.
Wonderful, thank you. Yeah, so what's really exciting for us, I think, is that we've just released our strategy, and within that we've got occupational illness, and the work that we've done so far on COVID, guidance documents, and we've just created a new safety plan builder app. So it's going to be online. It'll help business to quickly and effectively build a safety plan. That's something that's mandatory within the Reopening Ontario Act. It's great because it will actually prompt you for the specifics of your business, as opposed to what you had to do before with a generic template and just going to the website and trying to work your way through what it meant to have an accurate plan. I know today we wanted to talk really about vaccination certification. What does that mean for employers? What does that mean for patrons? And it's actually very timely. We had a Prevention Council meeting yesterday. We met this morning with some construction leaders, and then we met with the minister's office in quick succession. And that was the topic of the day. We recognize that the legislation, as it's put out, is there to deal with the public health crisis. And so it talks about patrons. And the government was really trying to not get involved in the employer-employee relationship. There are obviously certain areas where, you go into a restaurant and you have to prove your vaccination certification. However, your server who's serving you does not. And so there's some strange gray areas where we try and understand what does that mean for the employer as well as the employees. For the construction sector, we've certainly heard that because of the nature of construction, where you're moving from site to site potentially. I think, well, I heard this morning from the chair of the PC, Aaron Oliver, they have 50 different policies and procedures that they're trying to accomplish day after day to ensure that they can get the workers on site. And so it's starting to become an extremely heavy burden to lift. So we've made the commitment that we will work with the construction sector. We'll talk to the Ministry of Health and Economic Development, Job Creation, Trade to have the conversation, because one thing that we are able to, or that we know could be a potential solution, would be that if the Chief Medical Officer of Health, Dr. Moore, writes an order under Section 6 of his Act, like a letter of direction, that it negates or overrides the current Section 63 of the Act, where an employer needs to have consent in order to collect medical information. So if that order were to be placed on all construction employers, that makes it an easy or level playing field where, because of the order from the Chief Medical Officer of Health at the moment, Human Rights has deemed that checking for vaccination is not interfering with someone's human rights as long as there's consent or this order. So we're starting to see OLRB decisions going the way of employers, because it's reasonable that for the protection of workers, as Andrew said, you can be fully vaccinated and yet still get, carry, and transmit COVID. And worst case, there are breakthrough situations where folks are actually becoming sick. So as far as controls in the workplace, we don't expect that there'll be any direction whatsoever to reduce the masking, the distancing as much as possible. As Andrew said, those controls are extremely important in controlling the spread of the disease. And the vaccination is a powerful tool on top of that. So it still is not mandatory within the province. And we're trying not to infringe on people's decisions to choose whether they're going to be vaccinated or not. However, as Andrew said, the numbers are starting to really show that vaccination is a powerful tool for the protection of individuals. So, what does that look like in the work world? At the moment, it's kind of confusing. And, you've seen larger companies like Elliston and PCL announce jointly that they have a mandatory vaccination policy in place. We had a OGCA meeting last week where we were talking about the city of Ottawa had just put something in place, and they have actually applied the mandatory vaccination policy not only on their own employees, but anyone who's a volunteer and anyone who is a contractor working on a city of Ottawa property or project. So we're still trying to understand that legislation. We're still trying to ensure that we as the OPS, as an employer, we're providing good leadership. We're going to come up with the policy. I understand we just received an order as the OPS from the Chief Medical Officer of Health, so that'll help us put that policy in place. And we're striving to have that conversation. I don't know if Andrew, you had mentioned if there were questions that we'd be willing to take them. I know we only have half an hour on the panel. As far as any further updates related to COVID, we're on our operations side, so the Fair, Safe, Healthy Workplace Division. We are doing proactive visits, and we did Hamilton last weekend. I believe this weekend is Windsor, and then it'll be like Peel, Toronto, Ottawa in succession. That'll be publicly announced, where we want to make sure that we're providing compliance support. I think generally the feedback from the inspectorate is that they're seeing a reduction in compliance, even to like masking rules, let alone the vaccination certification. So I think there's a significant fatigue. Employers are having a difficult time keeping up not only with their own staff, but also with public. So, you know, it's just a difficult time right now. We're transitioning and absolutely we're here to help. We hear you loud and clear that a lot of this burden has gone to the employer, and we're going to actively work to try and find a solution for you.
I think there's some questions. I don't think we're anticipating being able to ask questions, so we appreciate that. If people have questions, you can put them in the question and answer. I can ask some questions that we've got from our Health and Safety Committee at RESCON. The first one might sound a little bit silly, but when everybody gets those rapid testing kits that they're using in the workplace, you get one bottle of solution. How long is that bottle good for? Because people want to test 5 or 10 workers. It comes in a kit of 25, and you know, what's the shelf life? It doesn't come with one of those best before dates like our milk cartons. So
I will have to get back to you on that. I don't know offhand. We'll certainly find that out for you. And that's been an issue, right? You can get a single, a 4, or a 25, and so you don't want to send someone home with a 25 if that's going to expire and they're not going to be able to use it. So definitely understand the question. I will get an answer for you.
Excellent. I guess, and you did kind of touch on it, but I think probably everybody wants to know, just for absolute clarity, what you guys, well, I guess not you, but what, if I can say broadly, the government has done with vaccine passports. That generally regulates the public space. Ministry of Colleges and Universities has enacted legislation for that sector. The hospitals have, you know, through health enacted legislation. You know, what is the process and what is the expectation or lack thereof? Or is there any clarity on whether we'll see something that from the Ministry of Labor that could impact construction in a regulatory or legislative fashion? I know you kind of answered it, but I'm getting texts on it still. So
yeah, sure. So at the moment, the legislation is very much directed at public, at the patrons. And the areas identified were done through a risk assessment lens. So areas of high groups or large groups of public, whether vaccinated or unvaccinated, were coming together in restaurants, cinemas, concerts, gyms. And so the concern is that those areas pose a higher risk of transmission. So the Chief Medical Officer of Health and all the public health guidance and data that we had so far identified that those were areas where we should put in place the vaccination certification program. That said, it does not speak at all to workers or workplaces. The only workplaces that you will see where they have an active policy in which they're able to ask for vaccination certification is a workplace that has received a letter of direction from the Chief Medical Officer of Health. That said, employers are allowed to put in place mandatory vaccination policies. Those policies, you know, they're coming under scrutiny now. So for instance, City of Toronto, workers are saying, well, you didn't ever ask for my consent to collect my vaccination information, which is under the Occupational Health and Safety Act. So that was what we were facing as the OPS. We had that same concern. We didn't know what legislation we could use that would empower the employer to receive that information without the worker's consent. So any business across Ontario can put in place a mandatory vaccination policy. The difficulty is, you know, legislatively, legally, how can they ask for information? You know, and that's even carrying into the private realm where, you know, a gym membership. Gyms are asking your vaccination status, and then they're trying to apply that to your membership. They're not allowed to do that. You know, that it's against the law. It very specifically states that you can ask for it, you can't store it or save it in any way, shape, or form. So even if a company puts a policy in place, the worker will still have to regularly, every time they arrive at that site, you know, you arrive at a hospital that you're working on, you arrive at Seneca College that you're working on, you're going to have to be asked every single day or every time you leave and come back to that property because they can't save it. The question will be whether or not they can extend their policy to you as a non-employee of theirs. Workers are very much exempt from the vaccination certification policy. You should be able to enter, say, I'm a worker here, and be able to enter those places, which is like the bars, restaurants, cinemas, anything that's listed. So the problem is, and we've heard it loud and clear, that owners are now holding contractors and their subs accountable through a contract. Say, well, you can't come into the site unless you're now vaccinated. And so because they can't enforce it through a policy, they're starting to move that into the contract, which really starts to impede on your productivity. It starts to, like, you'll lose staff, right? People will say, well, I can go and work in another company where they're never going to put a vaccination policy in place. And so given that there's already a shortage, that's really putting a pressure on construction in particular. I hope that helped clear it a little bit, Andrew. Is there something more specific?
Well, I think so. But we got two more questions as follow-up. So I guess on the collection of data, I think you were fairly clear, but one person asked, sorry for the clarification, if an employer does not have a vaccination policy, can we ask the employees for vaccination status or not? First, before I even turn it over to you, you have to have a vaccination policy. It doesn't necessarily have to mandate it, but it has to at least promote vaccination. The second question that's kind of like that, someone said, what legislation or regs are there that allow us to collect vaccination status? So I guess, they say it 3 times. So this will be the 3rd time. So just specific on the collection of data.
Absolutely. So there's already been a challenge against Section 28, which talks about having a medical surveillance program. That was, I believe, Elliston and the building trades went to the OLRB on that grievance, and it was in favor of Elliston asking for status because it's reasonable under it's a reasonable expectation of an employer under the Act, the 25(2)H general clause. The other section is section, now you're going to ask me and I'm not going to know exactly, I believe it's 65 sub 3, where of the Occupational Health and Safety Act, which states that if an employer wants to collect personal medical information from a worker, they have to first receive consent in writing. So you can put a policy in place, but then you have to have consent from your workers in order to collect that. And when I say collect, it's only verify. You can't save it. You can't put it on the personal file. You can't store it anywhere. You can ask at the door, and that's all you can do with it.
And I think that was great. And I know that we're going to touch on a lot of these issues with Mike in a couple minutes. One question that did come up, and we'll ask you guys, we'll also ask the doctor when he's on, is there any updates on boosters? And I don't know if you do or don't, but I know you guys sit at the COVID task force table, so I thought we'd ask that.
So nothing so far. We haven't heard anything on boosters. I know that even jurisdictionally, the States is different from Europe, and it's also dependent on the actual vaccine that you received and the doses. So I think we've heard that it may be possible that if you've had a Pfizer vaccine, you may have to get a booster. I haven't heard anything about any of the others.
Perfect. And then the last one is really a jurisdictional question, and it's a good one. This is why in the spring, AHID worked so hard on creating a vaccine cheat sheet, but essentially they're asking, why is there such separation between the feds and the province? I'd expand that and say, tell us about your jurisdictional nightmares when you guys are doing your work, because it's not just the feds and the province, it's feds, province, municipality, public health, and the work. So if there's ever a chance for you guys to get it off your chest, I guess now is it, right? So.
Yeah, well, we've heard it loud and clear from the Premier. He didn't want to separate the population. He didn't want to have the vaccinated and the unvaccinated because it's a choice. Over time, we've recognized, and now we're seeing that that if you leave it open to everyone, those who want to put a policy in place will then put in resources to build an app or to build a procedure in order to screen individuals coming into the workplace. You know, they've at the beginning they were doing that at their own detriment, because you know, people were upset and they're like, oh well, if you're a gym owner and you're putting up a vaccination policy, I'm just not going to come to your gym anymore, right? And we saw restaurants and different retail sectors losing patrons as a result of the policies that they had enacted. I think over time, the pressure was certainly high enough that the premier then, you know, in consultation with the chief medical officer of health, they came around to the fact that, okay, we need some form of consistent, easy access that we can use for individuals who are vaccinated to support employers who have those policies in place, and to identify those high risk areas where transmission can happen, to try and protect the population, like the general population. So they've kept employment or the employee-employer relationship separate, and they did that very specifically because, as I said, they didn't want to interfere with the relationship. Work is different. You can choose to go to a movie, you can choose to go to a restaurant, you can choose to go to a public place. You can't choose to not go to work, right? So the government doesn't want to mandate to say, well, you're not allowed to go to work anymore because you're not vaccinated. It's your choice. So, you know, that's why the policies, when put in place, could act as a barrier. If an employer is not willing to make any form of accommodation, that could mean that someone is terminated and loses their job. That's huge, right? That's someone's livelihood. So you can understand why we as government were trying to not put that layer of bureaucracy on top of the employment relationship, because work is different. And you know, you may have relaxation of how many people can gather and what you can do as a member of the public. But when you go into work, as you said, you know, the expectations are, you're still going to put on source control, you're still going to use PPE, there's still going to be spacing and barriers. All of that maintains in place because when you're at work, you have to be there. You're there for a significant amount of time and you have to be protected. So, you know, I think that's really the real narrative is you don't have a choice. You have to go to work. And so for those that were lucky enough, you know, as me, you can see, lucky enough to work remotely, that's been fantastic. However, most of the construction sector, I imagine, is not. And so you've had to go into work, which is why we fought so hard to make sure that construction was identified as essential. We extended hours of work so that people could work longer and get that time in and keep up productivity so you didn't get delays. And the construction sector at large responded very well. You know, you heard Joel acknowledging that at the beginning. You were first into the rapid testing. You were the first into tracking cases. You're the first ones that we've heard of taking surveys within your sector to identify vaccination rates or you know, what are the barriers for individuals who aren't vaccinated. So, you know, as much as it's a person's choice, I think construction's doing a significant amount of lifting, you know, moving mountains to try and make sure that individuals on sites are protected. So as I said, we'll do the best that we can to work here provincially to ensure that, you know, construction can continue to be as effective as it needs to be. You know, there's a lot of building going on. There's a lot of infrastructure being created right now, and that needs to be maintained. And that also certainly helps when you're coming into or there's a slow in the economy, right? So that's always something that can make sure that people get jobs.
Fine, and we'll kick it back to Mina to keep things moving here.
Thanks, Bill and Joel, and looking forward to continuing our relationship. And usually we only are blessed with one chief prevention officer, so we're happy to have two today. Moving on, our next speaker is Michael Sherrard, also known as Mike. He's recognized as one of Canada's leading employment and labor lawyers by Chambers Global, Who's Who Legal, Legal 500 Best Lawyers in Lexford. He is the former chair of the National Labor and Employment Law Section of the Canadian Bar Association and the Labor and Employment Law Section of the Ontario Bar Association. In October 2020, the Government of Ontario appointed Mike to the chair of the Skilled Trades Panel. Mike is acclaimed for his broad range of expertise, strategic excellence, and ability to identify and broker agreements in the most difficult and acrimonious of circumstances. Michael is frequently published and asked to chair or speak at international and national conferences, and he is the recipient of several awards, including the Construction Institute of Canada's Chancellor's Award of Excellence, the University of New Brunswick's Alumni Award of Distinction, Canadian Inter-University Sport Lester B. Pearson Award, and the Canadian Franchise Association Volunteer Leadership Excellence Award. Welcome, Mike.
Mina, thank you. Fair to assume you can hear me okay volume-wise? Okay, I'm going to try and share a screen if that's okay, so just bear with me for a sec. Okay, visible for everybody, Amina?
Yep.
Okay, thank you. So in the next half hour, I'm going to try to take you through some of this. I actually had the pleasure of listening earlier to comments, and they'll apply here. And then you've got speakers coming in behind me, specifically Dr. Wasser, who I'll defer to as you see some of these slides. But my hope is to cover vaccination policies, exemptions to vaccination, which we won't spend a lot of time on, the COVID vaccination liability, and then I'll try to make some comments briefly about vaccination passports, but there's a good distinction been made, obviously, by Bill Waugh earlier, and I appreciate that distinction. So let's jump into this. We know now this bullet, right? It says vaccination policies are now recommended by public health authorities. Andrew would jump in and say, no, it's mandated in many of the jurisdictions now. So it's not just simply a recommendation, but there actually are requirements in a number of the municipalities from our local public health groups that are requiring the policy. They're not requiring mandatory vaccination, but they are requiring you to have a policy. If you don't have a policy in place yet, you want to be in touch with RESCON. I know they've got a sample, and that can be quickly tailored by our firm, or your lawyer can help you tailor that pretty quickly. Generally, what we're seeing out in the public right now with our employer base is either a mandatory vaccination policy or what we're referring to as alternate measures policy for existing employees. We are seeing people put in place when they hire new employees, we're seeing people put in place a vaccination requirement as a condition of hiring. So that's a bit of a change over the course of the last 2 to 3 months. But if we're looking at existing employees, we are seeing some policies that say the only way we will continue to employ you past a specific date is if you are, my language for a moment, double vaccinated, but you want to be very careful with the definition because you heard that question from Andrew earlier, what's going on with the boosters? And so some people are being very careful with their definition of what being vaccinated means to include a subsequent public health direction if that's what in fact happens along the nature of the booster. There are some risks with mandatory policies, and please pay attention to those. So we're not here today to say to you, you must put in a mandatory vaccination policy. Just the opposite. We're trying to give you choices and flag for you what those risks are. So if you put in a mandatory policy, it comes with risks. The issue at the unionization, in a unionized environment, will be their ability to grieve and arbitrate the policy, let alone the application of the policy to an employee. And the issue really at arbitration, I think, will be, is it reasonable in these circumstances? That's really that's how simplified it's going to get. But they're going to look at things like, what did the employer do in advance of putting in a mandatory policy? Did they provide education? Did they provide incentives? What did they do to try to assist the workforce in actually getting vaccinated? We have lots of employers who have actually had clinics. I'll talk a little bit later about the rapid test, but some people are now thinking of, in that alternate measure, if you're not vaccinated, you're going to be susceptible to a rapid test on a certain frequency. And that's a debatable frequency. And we may hear from Dr. Wasser on that. Some people are asking the question, well, if I'm going to require a rapid test, who's paying for it? And again, employers, our comment for now is if you start with a rapid test and you're trying to phase in a policy, and again, I'm jumping a little bit into that alternate policy, but if you're putting in if you're not mandatorily, if you're not vaccinated, we're going to require the continuation of PPE, even if public health knocks some of those down in the future. And we're going to also ask you to rapid test. When you think about the rapid test, who's paying for it? Employers should think a little bit about the phase-in period. So for a period of time, if you, the employer, can source, for example, free rapid tests from the government, and I think they are still available, if you can source them, you may be best served by actually sourcing them yourself and providing them to the employee, and then potentially having a date off into the future where you may wean off of that and require the employees to do it themselves. I say all of that because that will become part of the reasonable analysis on your policy should it ever be grieved. So just something to think about. So the next one, in the non-unionized environment, you're going to want to understand whether or not can I terminate for somebody's failure to get vaccinated contrary to my policy that I've published, I've communicated, I've given advance notice of. And there's concern right now whether or not that will actually amount to just cause. And you need just cause to avoid any termination liabilities. So again, walk in with wide eyes that while you could put your policy in place and you could terminate, there may be a cost consequence as a result. And then the kicker at the very end. This is probably the most practical one that I hear the most amount of complaint about, is that I can't get enough labor on my site to begin with. Am I going to put up another barrier? So some people are getting quite caught in this area. And so that's why lots of people are thinking of the alternative policy where they're encouraging vaccination, but not making it mandatorily a part of the employment condition. Here's your alternate measures. So somebody comes in, says they don't want to get vaccinated. Remember, I'm not talking right now about a human rights-based reason, simply a self-choice reason. Here are all the alternative measures that most employers are implementing to try to maintain that workforce, but still protect the rest of their workforce. And frankly, trying to address the health and safety obligations under Section 25 that Bill talked about earlier. Legally, we think it's more defensible. It's less likely to result in employees leaving, especially as you see in similar policies around the industry. And for now, it's more common. Andrew's question earlier of the earlier panelists, very important. Will the government make a move at some point and actually make a move to mandatory for the purposes of employees, not simply for the purposes of business? Is that in the cards? And that may change the landscape. I can't tell you it's in the cards, but it's got to be a subject of discussion with various levels of government right now. You all know this already. When you put your policy out, and the sample policy that RESCON has shows that the employer is prepared to accommodate an employee who can't be vaccinated for medical or religious reasons. And that's important to have in there. Make sure that when somebody says to you, I'm not prepared to get vaccinated, ask them why. Simply ask them why. And when they say personal choice, you're going down a certain alley. If they say, I have a medical reason, you're going down a different alley. If they say, I have a religious basis for it, it's a different alley again. But ask the question, right? And ask the question, not, my view at least is, remember, we're still in the education phase. We've got lots of anxiety still with a number of people who haven't been vaccinated. And so a good set of ears, open-ended questions are really important when you're engaged with people trying to understand the rationale for not being vaccinated. This September, we got Ministry of Health guidance with respect to medical exemptions. And I suspect you may hear from Dr. Wasser later that there are very few actual contraindications with respect to a medical basis for not getting the vaccine. I've heard them. I mean, I've heard people with a peanut allergy as an example. who has challenges. And so don't take that. Remember, I'm the lawyer. I'm not the doctor that's about to speak. I have seen a number of challenges, but I've also seen a method by which somebody with an allergy or a peanut allergy can still get the vaccination with specific medical support. Maybe I get to ask that question of Dr. Wasser later on. But again, very few reasons that fit within the medical accommodation piece under the Human Rights Code. Now, remember that you're asking them to substantiate things, right? And sometimes there's a time frame, and sometimes there's an alternative manner, and that's the allergist piece I was talking about. We've actually had allergists present to ensure somebody doesn't have a negative consequence from taking the vaccination. If you're concerned about the legitimacy of the employee's assertion of a medical basis for not taking it, we think you want to engage a medical doctor. We want to stick with that science table as opposed to simply us lay people who we do want to rely upon the experts in this area. We move into the religious piece. The religious piece is an interesting one because we're starting to see a number of these pop up. We're seeing a lot of them, not so much in construction, but I am seeing a lot of them in the healthcare sector. An employee will generally be entitled to a religious exemption to the vaccination if they can demonstrate a sincerely held belief. That's number one. Now, most of the listeners should be saying, well, that's pretty easy. I can create a sincerely held belief. And I don't want to be that pessimistic about it, but it must be connected to a tenet of a religious creed-based organization or community. So it's not just simply Mike Sherrod thinks it up. It has to be connected to a religious creed-based organization or community. It doesn't protect a personal belief, right? It has to be sincerely held belief connected to a tenet. Here are the questions we think you can ask. What religion creed do you practice? If somebody is citing the religious belief for the basis for why they won't get vaccinated, we think you can ask them, what religion creed do you practice? How long have you practiced that religion or creed? Why does your belief in this religion creed prevent you from being vaccinated? And I'm reading them on purpose. They're straightforward, but those are the kind of questions we encourage you to ask when somebody puts their hand up and says, I have a religious basis for not getting vaccinated. And then the catch sometimes actually straightens this out a bit when we say, have you been vaccinated against any other illnesses? You get a positive answer back, and now you want to understand what's the distinction between those earlier vaccinations that you got potentially as a child and this vaccination itself. What was the difference? And then you ultimately can ask for some form of objective documentation, at least from our perspective. WSIB coverage, I won't spend long on this, but there have been a number of questions, both from people who aren't getting vaccinated and from employers and those who are now considering getting vaccinated. Well, what if I have a negative reaction? What if I suffer some kind of adverse reaction? Will WSIB cover us? And while the jury is out on this topic, we believe it is likely it will be covered. And I think, and somebody can correct me, I thought I heard early on our WSIB officials saying that they would also not apply that claim to the specific employer experience. So there was another piece out there on the WSIB side. The other one that you should take a look into, I think we now have the federal vaccine injury support program that is out and advertised. I would just caution you to make sure you read the fine print in that program, because while it's live, it's got a before and after date with respect to whether you're making a claim arising from a vaccine before a certain date versus after a date. So take a look at the program itself if you're interested in whether or not there will be support under the federal vaccine injury support program that our Prime Minister mentioned quite a while ago, but is now, I believe, up and running. And remember, they've got some very specific definitions on how compensation would be awarded on what basis. There's a threshold, and you can see it's a severe life-threatening or life-altering injury that may require in-person hospitalization or prolongation of existing hospitalization. And remember, that just to catch, right, we don't put "and" there just for the sake of putting "and." You need both of these, right? So it's and results in a persistent or significant disability or incapacity. So very important with respect to how one might make a claim if you're actually wanting to look into that. What remains to be seen, though, is what will happen with WSIB coverage and how this federal program will impact or not impact on WSIB coverage. So let me talk just briefly about the passports. We know that as of September 22nd, the passport requirement is in place, but really a critical distinction, and I think I heard Bill say it as I was joining the program, it's required for an entry into indoor premises, many of the non-essential businesses and the examples you've seen up there. But again, it applies only to patrons, not employees. And I think many employers in those kind of businesses are quite perplexed by the distinction. I want everybody coming into my restaurant to be double vaxxed, but the law or the legislative piece is not going to require my employees who serve them to be double vaccinated. And frankly, I think people find that to be quite a quandary. I am seeing businesses in that nature in the service industry as opposed to in construction. I am seeing many of them actually move to the mandatory policies, and they're taking calculated risks with respect to, one, how they put them in, lots of advance notice, and lots of education with their employees in terms of the why. Before I move from here, Bill made some comments around privacy and what we can ask or not ask. The only thing I would add to his comment, he talked about making sure we get written consent if you were going to record, and I don't mean keep, but like to get that information. The one thing I would add, what I'm seeing as well, is people are talking about, well, I may want to advertise, and not so much in construction, frankly, I think more service sector. I may want to advertise that my population that serves you is totally vaccinated. All I'd say in that one is make sure it's informed consent. So not just written consent that you've asked them for consent to collect it, but make sure you've asked them and told them when you're asking them for consent specifically for what you're going to use it for. And I think that informed consent, we miss that sometimes. And by the way, I'm not advocating collecting it all and telling everybody who comes into your restaurant. It's just, if you're going there, there's one way to reduce your risks. And I think Bill covered this as well, my third bullet. Why the distinction, why these non-essential? And again, indoor, higher risk of transmission. I was in a gym this morning as an example, and I was in a gym last Monday. Last Monday, there were 2 people in a 20,000 foot gym. This morning, there were, I'd say, 12 people in that 20,000 foot gym. Did this new policy help these businesses get people back and have these people feel more comfortable in those arenas? Possibly. We know that starting on the 22nd, it's a demonstration really from a paper perspective. And there's that hook, of course, that says you've gotten both doses and 14 days have elapsed. We know that we're being told there's going to be a QR code. I think the theory on that one is available by October 22nd. We also know that you'll need to carry identification with you that actually matches the vaccination. But we haven't seen yet, and I apologize if I missed it in the earlier part of the program. We haven't seen any suggestion yet that the passport requirement is actually going to get extended to the essential businesses. So I would certainly defer to the other speakers if they've got better information than I do on that, but I haven't seen that move yet or a hint of that.
We haven't seen it, and we've actually asked and been told the opposite. So they're specifically not looking to do that at this point.
Okay, and then maybe I just, I think, Andrew, I've tried to keep at least 5 minutes for some questions if that works for you. A couple of quick other things. I covered the rapid testing piece. I really do think the employers should be thinking about, at least on the front end of your program, thinking of if you're phasing in a program, front end, if you can access the rapid antigen tests free, think about providing them yourself as opposed to asking an employee to pay for them. Some people are doing that from now till November 1st, and then they're foisting it on the employee, the cost on the employee November 1st after, with the theory that we've given them sufficient education and time to actually get vaccinated. So I think there's a pretty good discussion or debate to be had there. Implementation of policies. I've heard a number of questions about when should we implement our policy? I actually think you can implement a policy today with an effective date off into the future. So I still love advance notice, but if I said to people, I'm putting in my alternative measures policy today, it will become effective, and I'm thinking out loud in the 7 or 8 week range, so that those who haven't gotten it yet, and they're getting the first notice from me that I want them to get vaccinated, you want to give them time to source a vaccine and then have that gap that we're advised that must happen between the first and second vaccination. A lot of questions around subtrades. What do we do with subtrades? Here are some ideas, and they are only ideas. I think you have to think long and hard, but with subtrades, we have some employers who have said, I want my subtrade to attest that they have implemented a policy that is comparable to my own. In other words, I don't want to become the employer of the subtrade's employees, but I can say to my subtrade, I want that subtrade to have the same policy in place or a comparable policy in place that looks like mine. I've also seen people say, I want you to show it to me. And I've also seen people say, I may audit it. I may at some point audit it, because we know that we have had GCs in different situations refuse entry to sites. And so from a subtrade perspective, I actually think you have to think about what's my customer requiring of me? Can I comply? Are there alternative measures that might still sync up with my customer's requirement? And what am I going to do on the other end? And I think I heard this earlier, that quandary, right? What about that shortage of labor that might be exacerbated if I'm forcing the vaccination as opposed to creating alternate measures? So let me stop there, and Mina or Andrew, invite questions if you want, or maybe get me a few minutes back. And can I stop sharing the screen? Maybe that make more sense?
Sure, yeah. So one of the questions has to do with the, I guess, the human rights perspective. What is a reasonable objective documentation for religious accommodation? Would it be like a note from a religious leader?
Yeah, so if we, just to catch both, Mina, so human rights, we know that there are prohibited grounds of discrimination, 2 of the prohibited grounds, 1 medical, 1 religion. To try to be direct to your question on religion, I think it has to be an institution that's recognized. And in other words, it ought not to be acceptable to have somebody, my words, and I mean this respectfully, hatch a religious institution yesterday and get a note. It's about a religious basis that is attached to a religious institution that exists and has been around. And I don't mean to be too pessimistic about it. And I'd want all employers to be very careful and be respectful of people putting their hand up to say, I have a religious objection, but there's a limit. Maybe we go back to that word again, reasonable.
And then there's a question, is there any specific guidance on vaccinations when it comes to model homes and design centers?
It's a great question. So I'd invite anybody else to jump in here if they have thoughts, because now what you're defining, right, is we're not on an open site. We're now in an indoor facility. And I think, my view would be it's more reasonable to require the mandatory vaccination. I still have a debate, and I'd love some, maybe Dr. Wasser or Bill, you'll jump in here. The idea that most people want the double vaccination. I've heard some people say double vaccination or a negative PCR test. And it's now been just double vaccination. And I wonder sometimes out loud only, if it was practical and reasonable and cost effective to get it, would a negative PCR test actually help us? I'm not so sure it's practical, I guess, at the end of the day. So indoor, Amina, I think there's a better basis to require mandatory vaccination.
Yeah, I would agree.
Sorry.
I would agree with that, Michael, but absolutely.
And just to jump in on that one, because if you sell a house to someone, there's a contract there. So I don't have an answer, but it has been raised with Tarion. So we will get an answer to members on that.
What about the reverse circumstances where we implement mandatory vaccination policies for employees but have customers/homeowners that we are exposed to as employees? Do our customers have a right to ask, and are our employees obligated to disclose vaccination?
Let me try to answer the last question, maybe, or the last part of your question, Amina. I personally, I don't believe customers have the right to say to Mike Sherrod or to Andrew Paris or to Amina, disclose to me your personal health information. I think that's something that employers actually should help their employees with, though. So they should already have planned for, when we get these questions, here's how they are to be addressed. So that's again, that can be part of a policy, and you'll help your employees. Because the other one that worries me as well is, I think we're going to get some heated discussions. And unfortunately, I think there's going to be the odd, what will fit a workplace violence event, unfortunately. And I think employers need to put in place that workplace violence risk assessment as well to make sure. So for example, if you have somebody at a front desk, at the reception desk inside a model home, is there something viable so that there's number one, there's a barrier between that person and the customer? Do we still have the old plexiglass barriers up? Can we try to ensure that person actually doesn't work alone? Some very practical, reasonable approaches to try to keep them safe as well.
Okay. What is best practice notification 8 weeks?
The reason I mentioned 8 weeks, I wouldn't say it has to be 8 weeks, but if you think of the medical evidence, at least the medical advice so far, and notice Dr. Wasser has joined us, so he'll hit this one for sure. I keep hearing that there is a recommended period of time between first vaccination and second vaccination. And that's what you want to be providing for in terms of, if you're putting in a new requirement and you've got people who may want to comply, there should be a period of time that actually allows them to comply, aligned with public health guidance in terms of the separation between vaccination 1 and 2. I think 8 weeks is safe in terms of somebody sourcing vaccination number 1 and then having a period of time and then sourcing vaccination number 2. Because my memory is, when you get your first, your vaccination number 2 is booked almost, is booked as you're doing it. But there is a gap, I think. But again, I mean, I'll stop there and just simply defer to what Dr. Wasser may add on that one.
And then there's a question, very long question, but I think the short question, and you'll probably have a short answer for it too, is do employers have to have a mandatory vaccination policy?
Short answer. Thank you, Mina. They do not have to have a mandatory vaccination policy, but in many of the regions in Ontario, they must have a policy. Doesn't have to be a mandatory one, but they must put a policy in place.
And then, do you have any insight as to the various unions' positions on vaccination policies and how they are educating members?
Yeah, I really can't add there. My understanding of what I'm hearing, but it's second and third hand, is that unions, again, are struggling, as we are as employers, with respect to whether to implement a mandatory policy or not. And I believe they're looking at even leaves of absence as a consequence of not getting vaccinated by a certain date. So I'm guessing a bit, Amina, so I should stop there.
Okay, so we have a couple more questions, if that's okay.
Sure.
Okay, so why is it recommended to share the alternative measures as a policy? OGCA shared policies for use for businesses that allows the business to not share those alternative measures up front, but to deal with those accommodations as they come, and include the employee in that development and use guidance of public health.
I think it's a policy position. Each employer has to make a choice, and they have to make decisions as to what kind of risks they're going to bear. And there are 2 risks that we've identified. If you put a mandatory policy in place, you are in a unionized environment, you're susceptible to a grievance and an arbitration. You could win it. It could be determined to be reasonable, but please be aware if you put a mandatory policy in place, you're susceptible to challenge. It'll be adjudicated by an arbitrator, I think, on the basis of whether it's a reasonable policy in this context or not. We know that Ellis Don was recently successful, but that was with respect to testing as opposed to with respect to vaccinations. And you just have to decide whether you want to run that risk. And then the second part, unfortunately, I think I hear many of our clients still talking about labor shortages. And so when you're struggling to get employees to come to work every day and have full crews, putting this other barrier in place, I think represents a problem. It doesn't mean you don't do it. It just means you walk in with wide open eyes and make your decisions accordingly with those risks in mind.
Okay, and then we'll do maybe two more. To clarify, it is reasonable to ask for vaccination status. However, if this information will be stored, would written consent or just asking them if like to store vaccination be required, or health information, I guess, just speaking broadly.
Yeah, I think I heard Bill talking about it earlier as well. And I think we're used to having privacy principles, and many employers on this call will already have a privacy policy. And so you start with the privacy policy. You also look to any of the provincial privacy legislation that would be applicable to you, the employer. And it's between those two that you look for what you can and can't do. And you heard Bill talk earlier about if you're going to do something, make sure you've got written consent. I add informed consent based upon use. The other thing we see at arbitration a lot in the unionized environment is we say, what was the employer's need to know? And did they use the least intrusive means to achieve that need that they wanted? And sometimes people have said, do I need to hang on to that vaccination piece of paper? I know I don't want to put it in a personnel file. I heard Bill mention that. I agree 100% with that. Do I even want to hang on to it? Is it possible? Is it possible that I could have my senior human resource professional in my company meet with Mike, and all Mike does is to show it to that human resource professional, and that human resource professional just checks off Mike's name. So Mike's company isn't hanging on to that personal health information. We've just got a list where we've checked names off, right? And that's one way of, I think, doing a least intrusive means of achieving the objective. One method.
Yeah, it's interesting. I think that when we move to the digital solution, like you said, it's October 22nd is that target, that likely the screen will have a check mark or an X, right? There won't be anything there personal whatsoever. You can't make any assumptions on what that means. It's, it's just that entry or no entry. So yeah, we're trying to find ways to ensure that privacy remains in place. Absolutely.
And then last question, can employers potentially be liable for COVID transmission in the workplace if they don't mandate vaccinations?
Yeah, my quick answer, and I don't mean to be too glib, I don't see that liability, frankly, but I make that on the assumption that you, the employer, have followed public health guidance through this process. And we know that public health guidance has evolved, and we've learned as we've gone. But I think employers who follow what public health is telling us to do, and remember, we think public health, public spaces, Ministry of Labor, Training, Skills and Development, workspaces, but they can sync up. And for me, they become a standard, right? I look to them for advice as to what level. And as long as I followed that, I think you can be sued. I mean, first of all, anybody can sue anybody, but I think it's not likely that somebody will be successful. And then the next one will be, will workers' comp play in there or not? I think I'll stop there, but I think it's highly unlikely, provided the employer shows evidence of their due diligence, for lack of a better word.
Thanks, Mike. A lot of questions on this stuff. So thank you for presenting. I know I always learn something new when you present at our events, so thanks for being here.
Thank you.
We'll move on to RESCON's own Ahid Al-Ashri, and she is going to present some preliminary survey data. So I'll kick it over to Ahid.
Good afternoon, everyone. I'll just share my screen quickly. Can everyone see that?
Yep, we can see it.
Okay. So recently, RESCON launched a survey about vaccine rates in construction. Yeah, so we launched it in August, and the goal was to understand more about the vaccination rates and just to inform the policies that we're making. We will be closing the survey end of September, but we just wanted to go through some of the rates that we're getting at the moment. These are the participating associations that we have with us. So a few of the highlighted findings in terms of vaccination rates, we found that a lot more work needs to be done on site. In comparison to what's happening in the work in the offices, the vaccination rates are much higher. The main reasons why some people aren't getting vaccinated are because of the fear of vaccine side effects and lack of information. And then hopefully we can hear more from Dr. Lasser about these things. And then for vaccine policy and promotion in the workplace, we need more policy, and more importantly, we need to promote it. So we'll get into a few of the questions that we asked. We started by asking our participants what sector of construction they came from. So far we do have 700 responses, and our goal is to get to 1,000. But as we can see, we have 25 residential, 24 heavy civil, 34 ICI, and 15 other. So it's a nice separation between all of them. Are you vaccinated? 70% said yes, and we have 24% that said no, I do not plan on getting vaccinated. 70% of the 700 is good, but there's still more work that definitely needs to be done. And then for those that said they do not plan on getting vaccinated, we asked why, what their reasons were. The main reasons were worried about the side effects and health implications. And with like 42% said that, and 28% said waiting for more data on vaccine safety from the government. So hopefully you guys can put some questions in the question area, and Dr. Lasser can answer some of that and give us some more, trust in the vaccine, I guess. Is your workplace encouraging vaccination? 70% said yes, 12% said no, and 16% said unsure. So as Mike said, and as Bill said, it's extremely important to have a vaccine policy, some language on the policy, but more importantly than that, you need to promote it. We're noticing that a lot of people, they don't know if there's a vaccine policy in their workplace. So having it is one thing, and then promoting it and stressing it is a whole other thing, and that's more important. Are you in favor of the province mandating vaccines for all essential workers, including construction? 55% said yes. 37 said no, and almost 7 said unsure. This is probably a reflection of those that did get the vaccine and those that didn't. So if you got the vaccine, you're probably more likely to be in favor of that. Next, does your workplace collect vaccination information from on-site workers? 59% said no, 20% said yes, and 20 said unsure. And does your workplace collect vaccination information from office workers? 50 said no, 23% said yes, and almost 26 said unsure. So because we started this in August, and that was the time people were still not collecting information. So we're hoping that by the time we close it in September, these numbers change. However, again, to stress it one more time, you need to have the language on the vaccine policy, and you need to keep talking about it and promoting it until you can decide as a firm or as a company whether you want to mandate it or not. And thank you. And then if you have any questions, you can just put them in the chat box, and yeah, we'll get to them. So next,
And maybe if the survey link just went in the chat again. So we're at about, I think, 700 right ahead.
Yeah.
So we're looking for another 300, and thank you to the associations that have sent it out. You know, once we hit 1,000, we're going to meet as a group and we'll go through it. But
So next we have Dr. Eddie Wasser. Dr. Eddie Wasser has more than 30 years experience in emergency medicine and pre-hospital care. He holds staff privileges at 2 University of Toronto teaching hospitals and a lead physician at the Cleveland Clinic in preventative and executive medicine. He has a Harvard Fellowship Certificate in Disaster Medicine, Executive Healthcare, and Dignitary Protective Medicine. Dr. Wasser is the Chief Medical Officer for Pearson International Airport and the Medical Director for Ontario Lotteries and Gaming Corporation, Canada's Wonderland, and many more. He has a master's degree in counterterrorism and has been the Medical Director for the Prime Minister's Protection Detail of the RCMP for the last 21 years, and the National Director for the National Director for the RCMP's Emergency Medical Response Program, and was the pillar lead for the critical incident response for the 2018 G Summit in Quebec City. He's a co-author on the chapter on protective and VIP medicine with 2 White House physicians in travel medicine. We're happy to have Dr. Wasser join us today, and we're looking forward to have him address some of the concerns the construction industry has around vaccines. Thank you, Dr. Wasser, for joining us, and the floor is yours.
Thank you, Amit, for inviting me. Thank you, Andrew, for inviting me. Now I get to see a face with a person. And Mike, I came in late, but I always enjoy, like Anima said, hearing you speak. I'm going to try and share my screen. Hopefully it works. Technology often doesn't like me. Let's see if we can make this work today. Where is my presentation? It's not coming up. Advanced files. Why is it not coming up?
if you open your presentation on your computer, then it pops up a little quicker sometimes, at least for me.
There we go. So
I know I have too many windows open too, so.
So let me try that again. Share screen. There it is. Yep, there we go. And we're just gonna go right up to the top here. And look at that. Love when something works. Okay, can everybody see my presentation?
Yes, it's up.
Yeah.
I'm just going to minimize this. Okay. All right. Thank you for that very kind introduction. My name is Eddie Wasser, and thank you for inviting me to speak on vaccines. I've done a lot of work in the area of COVID regarding my corporate clients, collaboratively with a number of institutions, and doing a lot of work in vaccine, and happy to answer any questions. I thank you, Andrew, for sharing the survey in advance, because it allowed me to have some insight, but also reassure me that I'm hitting on some of the salient issues that some of your membership or who have some hesitancy in vaccines will hopefully get over that. I believe a physician's job is not only to provide good medical care. Our job is very much education, and there's been a lot of misinformation, unfortunately, in the world of vaccines. I'm highly critical of the media and how they've handled this, and I think that's created a lot of angst and anxiety amongst many people, and hopefully I'll help allay some of those fears today. Let's start off by talking about just vaccines in general. Vaccines, they're recognized by the body as foreign. And that's a good thing, because if you had a splinter, your body would recognize it as foreign. And if you couldn't get it out, eventually it'll create a blister, isolate it, and so on. That's exactly what happens with a virus as well. Your body recognizes a virus as being foreign, and it activates its own immune system and will attack it. And that's exactly what vaccines are doing. Vaccines are basically tickling your immune system, alerting it that something is unusual, and let's address it. So allowing your own body to do its own work, using antibodies and lymphocytes, which are a component of your white cells. I don't know if you can see my mouse pointing to the kind of the crown, the coronavirus, little spiky things that we know that are in coronavirus. And that's what our immune system is being taught to recognize when we're given a vaccine. In Canada, there are basically, now it's not allowing me to advance my slide. Now, why is that? There we go. Whoops, there we go. In Canada, we have 2 approved vaccines that involve virus and 2 that do not. So the AstraZeneca and the J&J vaccines are both approved, and nobody has ever gotten any J&J vaccine.
Sorry, I don't think it's not switching. I'm still seeing the same slide.
We're actually looking at your
The first
not the
one.
presentation mode, but
Okay. So thank you for letting me know. Share is paused because your shared window to the front. Resume share. Let me try that.
If you go to the slideshow tab,
Yep. I apologize, guys. Stop share, and we're going to go back to share. And are you seeing it now?
that's done it. Yeah.
yeah.
Okay, so but for some reason, it's not letting me go up to the previous slide because this is not the slide that I wanted to look at the other slide first. As I said, technology does not always like me.
Try the left, the direction arrow on your pad. Try the left one there. That makes sense.
Yeah.
Or I think, okay. Do you want me to try and share it and you can tell me next slide?
Yeah, why don't we do that, Andrew? I sent Andrew a presentation just in case something like this were to happen. So I'm gonna just shut that down and allow you to go back and let Andrew open the presentation. And I'll go old fashioned way, I'll have to say next slide, please. I apologize to the audience.
Okay, and I just gotta share mine.
Mm-hmm.
You know what? Your PowerPoint doesn't like me either. It's using all my bandwidth here. Let me see what I can do. I'm sure I'll be able to figure this out though. Maybe I won't. Jeez. Can you guys hear me now? My computer's frozen.
We can hear you.
Okay. Well, that's not a great sign. So maybe you can continue with your deck and we'll see if I can catch up with the visuals.
Oh, you mean just open up my deck as if I'm talking to it?
Just pretend like we can see it.
Okay, which is really unfortunate because
I am going to send it to you, Amina, to see if it works better for you, okay?
Sure, yeah, no problem.
Yeah. So I'm going to go. So the next slide was AstraZeneca and J&J. And basically AstraZeneca uses a harmless, and J&J, a harmless altered version of the common cold virus, which is called the adenovirus. And the important thing about this is that the previous flu vaccines have used a very similar model, and the virus cannot make you sick. So it's a myth that the flu vaccine, as an analogy, will make you sick. Do people get a fever? Do they get chills? Do they get sweats and achiness after they get the flu vaccine? Sometimes, absolutely, but not because we're giving you the flu, but because your immune system's become activated and attacking the flu. And that means it's actually working. It's doing the job it should be doing. The same thing is true with the coronavirus, where your body actually is recognizing the little spiky protein that you see in all the images on TV of what the coronavirus looks like. Your body recognizes it after it's been tickled by the vaccine. And that allows your system to create antibodies for working against COVID-19 later. It's teaching your body basically how to respond if you become infected. It's as simple as that. It's not very complicated at all, actually. If you look at the mRNA vaccines, that's totally different. It works by introducing a piece of genetic code that tricks your body into producing COVID-19 antibodies. Not injecting a virus, not doing anything in the virus, just the code. So here's the problem. People are saying, oh my God, you're injecting DNA or RNA and so on. And I call it my myths of the vaccines. And myth number one, is anyone able to see these slides at this point? Because it would be very helpful. No?
Ahad and Amina are both trying to do it now. So
okay.
One of them hopefully will be successful.
So myth number one is that the mRNA vaccines are changing your DNA. That's complete nonsense. It's not even possible. And I'm going to tell you why. Because the vaccine doesn't go into the nucleus of the cell. You would have to go into the nucleus of the cell, which is where your genetic material, where your DNA is actually manufactured, in order, I think we're there. I just something pop up. So next slide. Go back. Go back. That's it. Exactly. Thank you. Nope. Next slide. Okay, so myth number one is that we're changing your DNA. We cannot change your DNA, even if we wanted to, because the vaccine elements are not going into the nucleus of the cell. The nucleus is the brain center of the cell. That's where your DNA is. And we can't change your DNA if we're not going into the nucleus. What happens is the mRNA vaccine basically breaks down, gets rid of the mRNA as soon as it unravels to basically tickle your system to activate antibodies so that, again, it recognizes the virus if you're infected. Myth number two is that the vaccine can change your blood type. I can't change your blood type even if I wanted to. I'm an emergency guy. You come in with a massive bleed from a car accident or somebody decided to do something nasty to you and you need a blood transfusion. I can only give you your blood type. I can't give you another blood type to change your blood because your body will react. And actually, that's what will kill you, not your injuries. There is exception to the rule, obviously. You always hear blood services advertising, we need O negative blood. That's the universal donor. But even when we give O negative blood to people, it doesn't change their blood type to O negative. They still stay as an A or a B or an AB or whatever. So myth number two about the mRNA vaccines is that basically it changes your blood type, which is not even possible. Next slide, please. Thank you, this is very helpful. Myth number three is that the mRNA vaccine is brand new. It's not new. mRNA vaccines have been around for more than a decade. It's been used in flu vaccines. It's been used in Zika. That was a nasty illness that was mainly seen in Brazil, but it worked its way up through South and Central America and even into parts of North America where there were very sadly deformed babies. It's been used in the rabies vaccine. It's been used in cytomegalovirus vaccine. So this is not something new. And that's, again, a lot of the mythology in and around the vaccines. What's really cool about the mRNA vaccines is that the future of vaccines is that you will only need perhaps one vaccine with multiple illnesses attached to it, so you won't have to get series of vaccines. So for example, a future mRNA vaccine may be not only for COVID, but it may also be COVID and flu. It may be COVID, flu, and the hepatitis A and B Twinrix that we recommend people use for travel, or Shingrix, which you recommend for shingles. So that's the future of mRNA vaccines, but this is not new. This has been around for a decade, and that's a lot of the mythology and scare tactics and so on. Next slide, please. Myth number four is that it's not FDA approved. Well, I find it actually quite curious because why we as Canadians should even care if a drug is FDA approved. FDA is the American regulatory authority. Health Canada is the Canadian healthcare authority. There are many drugs that are approved in Canada that have never been approved by the FDA and vice versa. There are drugs that are approved by the FDA that are never approved by Canada for a multiplicity of very complex reasons. And it's not uncommon to have one drug approved in one country, not another. But the fact is, by the way, they're all approved now by the FDA. The FDA has approved the vaccines, as has Health Canada, as you can see to the right of the slide. But the FDA not officially approving it, it was an emergency approval, is actually a legal definition, not a medical definition. There are legal requirements for full approval. All drugs get temporary approval before they get full approval. This was an emergency approval up until recently when it had been fully approved. So there's a lot of mythology around that. And then the next myth, of course, myth number five, is that this was developed too fast and therefore we really don't know anything about it. So I will address 2 points to that. Number one, it was not developed too fast because we've been playing and tinkering with mRNA vaccines for more than a decade. That's number one. Number two, the development of any new drug, it's a process consisting of 3 phases: phase 1, phase 2, phase 3. And then the drug gets approved, licensed by the regulatory authority, in Canada's case, Health Canada. And then phase 4 is once the drug is on the market for ongoing monitoring of the safety of the drug. And if there's any, what we call signals that, hey, we missed something in the research phase, that we should go back and look. And that's happened in history for sure. Phase 1, 2, and 3, the biggest holdup in phase 1, 2, and 3 is not the science. It's not the effectiveness of the medication, or in this case, the vaccine. It's the fact that the people reviewing the files are sitting on 100 or more files each of new blood pressure pill, new antibiotic, new cholesterol pill, new cancer drugs. So their focus is all over the place. When the pandemic started, they realized they were going to have to be looking at potential vaccines. They were told to take all the other products off their desks, sweep them aside, and they're to focus all their energies, all their days just on the pandemic vaccines, and that's what sped it up. So what they did was they took out the bureaucracy, not the science, not the ethics of this, not the morality of this. They just took out the bureaucracy, which sped it up, and in a good way, obviously. pregnancy and fertility risk. There's been a number of studies that have shown we now have literally tens of thousands of women around the world, including in Canada, who have given birth to very healthy babies after having been vaccinated. There's no evidence that it affects fertility. I actually spoke with a reproductive endocrinologist about 6-8 months ago, saying there's no science to say that it would cause any more risk of fertility risk than any other medication for that matter. And in fact, we know, and tragically, there have been cases where moms, while pregnant, have gotten coronavirus and passed it through the placenta to the baby, and both mom and baby have died. One of the most common things we hear, and I found it fascinating throughout the last election, which ended on Monday, was with the exception of medical contraindications, medical exemptions. And I did a ton of research on this, and I would ask my colleagues, and everyone kind of, I don't know. So what I did was I reached out to colleagues, and I'm staff at 2 teaching hospitals in Toronto. I reached out to colleagues in literally every single internal medicine specialty: neurology, cardiology, respirology, endocrinology, diabetes, thyroid disease, gastroenterology, rheumatology, people with rheumatoid diseases, oncology, cancer specialists, and so on. And I got an answer back from every single 100% of the physicians responded. And they all said that in their discipline, in other words, in cardiology, in respirology, et cetera, there are absolutely no contraindications. There are no exemptions for getting the vaccine, with 2 caveats. Caveat number 1, the patient has a known allergic reaction, serious allergic reaction to a previous ingredient from the vaccines. That would be legitimate, obviously. And in those cases, those patients should be admitted to the hospital to get their vaccine. I'm actually aware of one patient that had that done, and they were monitored overnight in the emergency room, and nothing happened, thankfully. And they went home the next morning, but they were there in the emergency in case something did happen, et cetera. The other condition was back from the cancer specialist, the transplant specialist, and the doctors who deal with patients with real autoimmune disease. When I say real autoimmune disease, I'm referring to people who are in active cancer care, who are on anti-rejection drugs for transplant, or patients are on what's called biologics, drugs for people with severe Crohn's disease, severe rheumatoid arthritis, et cetera, where their immune system has been downregulated. And in those conditions, the specialist said they're not contraindicated. What they need to do is speak to their specialist for best timing relative to their treatments of getting the vaccine. Because their immune system is downregulated, if you remember from my first part of this talk, it's your immune system that's doing all the work. We're just tickling it. What will happen is, because your immune system is downregulated from your chemotherapy or your radiation or your biological drug, then what happens is the timing of the vaccine is important, because you may end up with a blunted or a delayed response to the vaccine. So we want to time it perfectly relative to your chemotherapy, biologic, et cetera. But it's not a contraindication. The other contraindication would be someone who had a very serious reaction, obviously, to a first vaccine. And when I say serious reaction, I'm talking about anaphylaxis, where they could not breathe. I'm talking about those with myocarditis and pericarditis, and I'm going to talk to those a little bit later, and so on, or massive stroke, of course. But those are really rare, and I'm going to show you some data how rare they are. The other one, which is as fascinating, is religious reasons. Now, I'm the farthest thing from anyone who knows about religion or to espouse religious philosophy or theology, but I did reach out to people who do know. And I said, can you please educate me? Share with me what I can do, what I can use for presentations. Next slide, please. What I found was not a single major religion actually has a prohibition against vaccines. In fact, to the contrary, all the major religious leaders have supported vaccines. The Pope himself, because there were some questions about the vaccine, the AstraZeneca and J&J specifically. The cell line originated from an aborted fetus in the 1970s. So if that fetus was aborted or it was a miscarriage, no one's ever going to know. There's no way to know. It's back in the 1970s. That's number one. And number two, the Pope himself. And the Pope Emeritus, Pope Benedict, was still alive, but no longer the Pope, basically said, this is life-saving. You have an ethical obligation. And refusal to have the vaccine is suicidal. Furthermore, it is an ethical choice because you're not only playing with your health and life, but you're also playing with the lives and health of others. Quote unquote, I have signed up, one must do it. And mRNA technology is not new. Next slide, please. Jewish leaders, Muslim leaders have said one has both a religious and moral obligation to protect their families and their neighbors. Many of my colleagues and others have said, well, Jehovah's Witnesses would not get it. I reached out and I did my research and found out that Jehovah's Witnesses have removed vaccine prohibitions in the 1950s. Mormons have no religious prohibition. Every major religion has basically not created a prohibition from getting vaccines. So the medical exemptions and the religious exemptions seem to be losing the strength of their arguments of those who are anti-vaccine. Today, the most common form of COVID out there is the Delta variant. And here's the crazy news. 90% of Canadians and Americans, our closest neighbors, that's why I included them, are unvaccinated or partially vaccinated. Those in the hospital, that's awful. Look at Iceland, 90% of their population is fully vaccinated. And as of last week, they only have 10 patients in the hospital. I mean, there's a statistic that you just have to, you can't ignore it and so on. The Delta strain is the most common strain today. Next week, it's going to be the Lambda. It's going to be something else, something else. Don't be frightened by that. All viruses mutate every year and create multiple strains. They are living organism viruses, no different than you and I are a living organism, and it's survival of the fittest. They're basically constantly morphing, constantly mutating, constantly creating different variants to stay alive. The good news is that basically we're able to nip them in the butt, and it's not common that the other ones are going to be more virulent than the Delta is now. Could it happen? Absolutely. I don't have a crystal ball to be able to say that it's going to happen or not going to happen, but at least we know we're able to nip it in the butt. Mixing vaccines, there's 3 studies, a British study, a German study, and a Spanish study that showed that not only is mixing and matching completely safe, it actually is likely more effective than just sticking to one class, two AstraZeneca or 2 mRNA, Moderna or Pfizer. There are other challenges, practical challenges with that, I'll address a little bit later, but basically mixing and matching is completely safe and in all likelihood more effective. And in that regard, Canada turns out to be, our Canadian experiment, we call it, turned out to be the right thing to do. Having COVID in the past does not protect you. That is a myth. Why is it a myth? Because likely the COVID that you had 6 months, 8 months, a year ago was not the Delta variant, and the Delta variant is the predominant variant, and the Delta variant is much more virulent. But the latest studies have shown, as literally as last Friday released, is that a combination of having COVID and the vaccine protects you, and rather than just getting the vaccine alone or having COVID alone, and so on. But certainly, it doesn't completely protect you. Third doses, is this a booster or is it another dose? Latest data suggests, and I attended an all-day meeting last Friday, that the third dose is not a booster, but rather a completion of a series. Very much like the Twinrix, the hepatitis A and B, is 3 shots. Very much like Shingrix, the shingles vaccine, is 2 shots. We don't call shot number 2 and shot number 3 boosters. In all likelihood, you're going to need the third one in order to get the maximal effect. Third doses are here. They're here for our immune compromised. Our long-term care residents are already getting it. And each year we develop a new flu vaccine and we take all the existing previous strains and we tap on the newest strains to them to make them more effective. Quebec and Saskatchewan are the only provinces to date, I'm sure the others will follow, creating a third vaccine for travelers because for some reason, some countries will not recognize mix and matching, and some of the cruise lines, if you're going on a cruise, will also not recognize mix and matching, and therefore they're offering a third vaccine so that you're not precluded from traveling to those countries or going on a cruise. All the levels of government have basically are enforcing vaccines, the vaccine passport. Every province has jumped on board, all healthcare facilities. I'm quite surprised, but I'm quite thrilled that universities jumped on quite early, and the school boards are jumping on board as they should be. Next slide, please. Crystal ball, employees tell me every day, literally every single day, patient says to me, I want to come back to work. I'm eager to come back to work, but I need to know the guy sitting next to me is fully vaccinated because I don't want to bring anything home. I don't want to get my spouse, my children. I live with my elderly parents, or I have contact with my elderly parents, or I'm responsible for my elderly parents. I don't want to bring anything home. And don't we as have a responsibility to take care of our employees and take care of each other in that regard? So more and more companies are adopting vaccine requirements. I've been working with quite a number of them. And more companies are adopting testing of unvaccinated. Initially, and I don't want to get into the legalities because this is certainly Mike's area and I have no expertise. I don't like to go into areas I know nothing about, is that whether the employee pays or the employer pays. But what I'm hearing from my clients is that we are willing to pay up until a certain time, but we're not paying in perpetuity. This is going to be too costly, and if you don't want to be vaccinated, that's your choice. Bioethicists, constitutional experts, labor law experts are becoming very clear in their messaging. This is a public health and moral imperative. There's no provincial or federal prohibition. We heard this right from the beginning. Oh, it's against the law. There's no such laws that stay that, and I'll stay out of Mike's space. In fact, there's lots of Canadian precedent: smallpox, polio, hepatitis, etc. And the Human Rights Code allows for limited infringement for the greater good. I could not think of a greater good than coronavirus. But I want to say everyone's worried about privacy, as I am as well, about my patients. I have an obligation and to protect my patients' confidentiality. Have you been to a restaurant recently where you use a QR code? They ask a lot of very intrusive questions: your name, your phone number, your email. They ask you all these symptoms. The vaccine passport says one of your colleagues in the call just said a few minutes ago, is just going to have a tick mark, and all they're going to have is your name. The back end is going to be your name, your OHIP number, and you're vaccinated or not vaccinated. So there really is no infringement on your privacy or databasing. I have no idea what the restaurant's database is when they're asking me all these questions when I go out for pizza and wings. Good news, bad news, real news. The bad news is COVID's not going away, guys. The flu has been around for 100 years. COVID will be around hopefully for a lot less, but we don't know. And we basically, it's here. The good news is an incredibly effective treatment has been developed, and it basically is saving lives and preventing death. And the real news is we're going to learn to live with this and learn to function. We already have, we already are. We're very resilient as a society, but we can only take so much. Next slide, please. So the gold medal is no hospitalizations, no ICU admissions, no deaths. Every single year, sadly, before COVID, several thousand people die of influenza. They will continue to die of influenza. And I'm not trying to be dismissive or flip it. And people will continue to die of COVID. But we have a means to protect people and help people in the best way we can. Next slide, please. So a guy named Edward Jenner in 1749 invented the very first vaccine ever for smallpox. Smallpox killed 300 million people. That's 10 Canadas. And an article I read literally last weekend, the single greatest life-saving invention in medicine of all time, more so than penicillin, more so, can we go back? Sorry, we just lost my slides. More so than any other medical invention. On the other hand, Andrew Wakefield, the founder of the anti-vaccine movement, a physician, had his medical license revoked for falsifying hiding all his research data. It was complete fraud. He was also convicted for fraud because he made $43 million on profits from selling an autism kit. Remember, this is the guy who goes around and has told everybody, the anti-vaccine movement, that vaccine cause autism. There's not one stitch of evidence to prove that. And furthermore, his test kit that he invented and made $43 million tests for autism. And in fact, the studies have shown there is no test for autism, and we all know that. Next slide. Reality check. As of 2 days ago, 6 billion doses have been given globally, 2.5 billion fully vaccinated people, 55 million doses in Canada, 26 million fully vaccinated Canadians. We prevented 140,000 deaths in 5 months and 3 million new cases of COVID in 5 months. There is the take-home message. That is a home run in every definition of a home run. Next slide, please. I'm coming to the end. No medicines are 100% safe. It would be disingenuous and dishonest of me to say that everything is 100% safe. We don't know everything. We've learned a ton. We're learning a ton. But here you go. On 50 million doses, this is Canadian data, not global data, 0.028% of the population have had an adverse event, and only 0.008% of those patients have had a severe adverse event. What are these events? So everyone talks about myocarditis and pericarditis. So myocarditis is infection of the heart muscle, the myocardium. Pericarditis, infection of the sac around the heart, the saran wrap that wraps the heart. I've had pericarditis twice in my lifetime, many years ago. Viral infection. I didn't end up being hospitalized. I ended up in the ICU, and I'm here to tell the story. There are 3.1 million new cases of myocarditis and pericarditis every year in Canada, long before anybody ever heard of COVID. If you want to use the rule of tens, I couldn't find the exact number for Canada. Let's say that's 300,000. If it's 10%, if you want to do 1%, it's 30,000 cases. There were 716 cases of myocarditis or pericarditis related to the vaccines. Not zero, for sure not, but infinitesimally small. 15 cases of cerebral venous thrombosis, a very rare phenomenon outside of this situation with AstraZeneca. I've never seen one in my 30 years of practice. Guillain-Barré is a neurological condition 76 cases, possibly related to the vaccines. Let's say probably. Let's give it the benefit or the negative of the doubt. Typically, without vaccines, we have between 370 and 850 cases of Guillain-Barré a year in Canada, unrelated to COVID. And the real win, I heard a bioethicist last month speak, and it was a brilliant talk. Why are we constantly spinning a negative on the vaccines? Why aren't we making this a positive? Vaccines empower you to become secured physically, physical health and mental health. It opens up the doors for you to go travel again, to go watch the Leafs, the Raptors, or the Blue Jays play, go to restaurants as you like, go to movies, a sense of normalcy that we desperately need and want, and change the I can't do it to I can do it. And that's my presentation. I welcome any and all questions from the audience.
Thanks, Dr. Wasser. We do have a couple questions. The first one is, if having COVID does not protect you, or having previous infection does not protect you, why is the Ontario COVID-19 workplace and employee screening making exceptions, i.e. the same exception as fully vaccinated? So if you've had COVID-19 in the last 90 days, that's part of the screening tool.
So certainly if you've had a COVID-19 within the last month or so, your antibodies are at the highest level they ever will be, and then they'll wane over time. And that's true with vaccines as well, by the way. And therefore you're most protected during that window. But after that, your immunity drops and drops and drops. For people who had it earlier, they did not have the early year plus. We did not have any Delta variant. Delta variant didn't exist. So those people are completely unprotected from the Delta variant, Lambda variant, or whatever variants pop up on the street tomorrow or next month. So that's where that protection comes from early on after you've had an acute illness, but that basically will go away over time. We haven't seen the herd immunity that we see in other viruses with COVID yet. And just to let you know, herd immunity, everyone loves to talk about, there's natural herd immunity and the vaccines impose herd immunity, and of course the combination of the two. Natural herd immunity is different in every disease. Herd immunity in measles is different than mumps, is different than chickenpox, is different than COVID. So we can't say, oh, what percentage of the population have to have it to have herd immunity? We have decades of experience with mumps, measles, rubella, chickenpox. We do not have that experience with COVID. And that's why the number keeps moving from 70% vaccinated combination with natural immunity, creating herd immunity. And now we've jumped to 90% because we have not seen it with 70%. If you look at countries that were really aggressive early in vaccination, Israel, Bahrain, others, they hit 70% plus vaccination and they did not hit herd immunity. And that's why the bar keeps moving. So look, we're learning every day, obviously, about the virus. It's relatively new in society. It's only a year and a half that we've experienced this. I hope that answered the question.
Yes, I believe it did. There's another question. Employees are willing and want to return to work, but only if they can verify the person sitting next to them is vaccinated and safe. But can't vaccinated individuals catch, carry, and transfer the virus as well?
So the answer is yes, yes, and yes. Vaccinated individuals can catch, can carry, and can transmit the illness. But here's the difference. We have almost no hospitalizations of vaccinated people. So again, I don't want to sound flippant or dismissive. I actually don't care if I get COVID. In fact, if I get COVID, I'm actually offering myself additional immunity to the 2 vaccines that I've had, or a third someday whenever I get that. So what I'm preventing you from getting is the hospitalization, the ICU. COVID, we're not getting rid of COVID. We're still going to have it. We're just not going to get very sick from it.
Okay, you froze a bit, but I think we got the gist of that. There were a couple questions earlier during the webinar about boosters. Any idea on, and I know some of them are already available for people who are immunocompromised or have certain conditions. Any idea on boosters for like everyone across the board on when those?
I don't have any insight, but I'll be very honest with you. The data shows waiting 6 to 8 months. 8 months is the magic number being used now by the Israelis and in Bahrain, the two countries with the greatest experience of longevity of vaccine. There is chatter about 6 to 8 months. So people should think that way. But the longer you wait, the better, by the way, in the 6 to 8 month period. And the longer you wait, the better, because the developers are actually tweaking the vaccine to account specifically the Delta variant. Remember, the original vaccine did not account for Delta because Delta did not exist, right? Now we know Delta exists. So it does down-regulate Delta because it has a broad spectrum, but it's not specifically targeting Delta. So here's the example. Every year, the flu vaccine comes out with the old variants and the new variants from Asia. That's how we invent the vaccine, because we know what's going on in Asia 6 months before. And sometimes we miss them. We miss them, so we get more flu that year. But we don't get as many sick people being hospitalized because it still is able to tickle even the variants we didn't actually specifically target to some extent. So it does have an effect. But if you wait longer, the effect is greater.
And then we have a couple more questions. So there's a decent amount of health and safety and HR professionals on the call. And if they're not already, they're going to be required to talk to workers who may be vaccine hesitant. Do you have any advice to them in terms of how these conversations should go, or what they could be saying to these employees who are vaccine hesitant?
Yeah, so if they're vaccine hesitant because they're worried about, unfortunately, we've never seen this degree of misinformation and disinformation. A study done about 2 months ago showed that all the misinformation and disinformation, or the mythology of the vaccines, actually emanate from 6 anti-vaxxers around the world. Well-known, prolific social media people and anti-vaxxers. 6 people have caused this mess with regard to all this mythology. So I tell people, don't go on social media. Don't go to Facebook or Dr. Google. Go to reputable sites. If you want to stick to Canada, because we're Canadian, you trust Canadian data, go to UHN, University Health Network. Go to McGill's website, McGill University website. If you're trusting of American websites, the Mayo Clinic, the Cleveland Clinic, Harvard, brand name places to go to with lots of information. Unfortunately, there's a lot of self-proclaimed experts in the area, and even physicians. There's one guy who's prolific, and people reference him all the time when they meet with me. They go, "This guy's from the Mayo Clinic." So I'm not dumb. I do my research. I go in, I dig in. Cleveland Clinic, sorry, not Cleveland, the Mayo Clinic. The Mayo Clinic has completely disavowed any connection or relationship with this person. He never trained there. He did 1 month rotation during his training. That does not make him a Mayo Clinic doctor. They would even accept a guy like me to do a month rotation at Mayo Clinic if I asked them when I was training. He actually is in Idaho, not the epicenter of science and brilliance in the world, I can assure you. And the Idaho Board of Medical Licensure is taking away his license. It's in the middle of the hearings. This guy claims to be a Mayo Clinic expert and co-developed the mRNA vaccine. Complete mythology, a complete lie. And the problem is people are looking at all this nonsense. So tell people when they ask, if you don't want to believe me, you don't want to believe your employer that's saying this is good for everybody, go to reputable websites. People who have a personal interest. The university centers have no interest. They have no benefit financially or any other means to advocate for something other than it's good medicine and good science and good for the public. I hope that helps.
Thank you. And then there's a question on vaccines for kids. Any idea on when Health Canada will approve vaccines for kids?
Great question.
5 to 11.
So Friday, I was told that the FDA is literally this close to approving ages 5 to 11, so over 4. The Israelis have done a large study. The Europeans are doing a large study. So it's coming. Look, nobody ever wants to make a mistake on anybody, but certainly not on children. We pay a high price tag on our children. I'm a father as well. We would never want to make that mistake. So we start the older and we work our way backwards. And we now know it's incredibly safe on our teenage kids. And the clock is moving back. So Canada is looking at the data. I don't know what the timeline. I don't work for Health Canada, and they're very secretive, as they should be. They don't want to slip anything out in advance. But I do know it's an active process, and the Americans are about to approve age 5 to 11.
And then there's another question on back to boosters. Will it be like a continuous booster, like similar to the tetanus shot, where you get it every, or will it be more like the flu shot where you're supposed to get it every year?
So I'm not a vaccine developer or virologist, but in the talk I was at last Friday, which consists of an international group, by the way, of experts, and one of the leading vaccine researchers in America from an academic institution, not from a pharmaceutical company. She said that basically this is going to likely be for the next X number of years. It's going to be like an annual or twice a year booster. Once we get the final, once we figure it out, is it 2 doses or 3 doses of the primary series, we call it, and then there'll be boosters. And she predicted once or twice a year, like the flu shot, more so than a tetanus, which is every 10 years. Particularly speaking to a group of people in construction, I hope you're all updated in your tetanus. Tetanus is alive and well in Canada, and you don't get tetanus from rusty nails. That's a myth. You get tetanus from cuts that are contaminated with fecal contaminants from rats and mice and birds and flies that poop on it. So it won't be 10 years. It will maybe be once a year or twice a year. It's still part of the learning curve.
Perfect. And then the last question. Someone asked, I noticed your data on the vaccine, but I'm wondering what the rate of recovery is if you get COVID. If the rate of recovery is higher than those numbers of the side effects, what is the actual benefit? So I'm not entirely sure what the question is. What is the benefit of, I assume it's what's the benefit
I think I
of
know
getting
where this
the
question is
vaccine?
going. The person asking the question, please be, I welcome clarification. People say the disease is not worse than the vaccine. But we don't know that, right? So the amount of people that have serious reactions is infinitesimally small. I'm talking about serious to end up in a hospital from the vaccine, serious enough to give you a massive cardiac event or stroke and so on. Those numbers are infinitesimally small. Even the case of myocarditis, which are very common, as I showed you, how many people get myocarditis and pericarditis a year is very high. Very few of those people ever end up in the hospital or ever end up really sick. I had pericarditis, they said, twice, and it was uncomfortable, I can assure you. I had chest pain, shortness of breath, walking up a flight of stairs, but it went away, and I'm here to tell the story, and I'm an active person, no long-term consequence. And that's saying what we're seeing with the pericarditis and myocarditis from the vaccines. So the question is the illness worse than the vaccine or the vaccine worse than the illness? I can predict what the response to the vaccine is going to be. I can't predict what the response to the illness is going to be. And while the vast majority recover from COVID uneventfully, those who are quite sick are terribly sick. A gentleman, 38 years old, basically came in unable to breathe. Here's a healthy, fit guy, father of 2 young kids about to start school, and he could not breathe. His oxygen saturation was like 80 in normal oxygen saturation. Right now, we're all floating in the area of 97 to 100%. We get worried about you when you start hitting the low 90s, and he was like barely 80, and literally thought he'd never see his spouse or his kids again. That's a serious disease, and I can't predict if you're going to get serious COVID or not serious COVID. We had a death yesterday in the West. I don't know if you saw that. In the 20s, someone died. People die from this disease. And I do believe we have a greater public moral responsibility. Our hospitals have already been feeling stress fractures for years. Our hospitals are collapsing under their own weight. And sadly, our nurses are quitting in droves because they're overwhelmed. They're burnt out. And we have doctors who are burning out as well. So it's not just about you getting the illness. We do have a moral responsibility to each other as a society. And I'm not trying to be higher than now. This is reality. Our hospitals were on the brink of collapse last spring, and Alberta, right now, their hospitals are collapsing.
Thanks, Dr. Wasser. I think that's all the time we have for today, but I truly enjoyed the myth busting. I think it's super helpful to our members and the attendees here today. So thank you.
Thank you very much. Thank you, Andrew, for reaching out to me. I really appreciate it. Have a good day, everyone. Be safe. And Andrew, I welcome other questions offline if your membership would like more things clarified or answered if I wasn't clear or didn't answer something they really wanted to address. Okay.
Much appreciated. Thank you.
Everybody stay safe and get shot.
And I'll kick it back to Andrew for some closing remarks.
Yeah, thank you to all the speakers, including Dr. Wasser. And I think we will follow up. I'm just trying to unpin Amina there. We will follow up on that kind offer. And so, because I know there was a couple more questions that came in to me, but just as closing remarks, I'm not a lawyer, I'm not a doctor, I'm not a CPO, but one thing that does seem to be pretty clear is getting the vaccine is a good idea. And as we said at the start, it's 40 times or 42 times less likely you'll end up in ICU if you get the shot. So we do these webinars, they're a bunch of work. We're lucky to get great speakers. So we've still got Bill, Mike, and Dr. Wasser on. And so thank you guys very much. But behind the scenes, there's also a lot of work that goes on with RESCON. And so obviously, Ahid and Amina do the bulk of it. And I always just try to take as much credit as I can. To really kind of finalize it here, I will get Ahid or Amina to put the survey link in the chat one more time. I did promise you'd see that. I can also promise that if people don't complete the survey and they don't share it, we're going to keep promoting it. So let's all do each other a favor and let's get to that 1,000 sooner rather than later, and we can all, move on from this survey promotion. But I guess the other thing that we've learned, even since the spring, is this probably won't be the last time you see us. I think we understand COVID a little bit more every time it goes by, and we're starting to understand the vaccination part of it, as time goes on. And so we always welcome feedback. One last round of thank yous. But we also thank all the construction workers out there and all the staff and in-office workers who, one, have gotten vaccinated, who, two, are promoting it, and three, have essentially created, a safe community and a culture of safety in construction that has allowed us to stay open and work in partnership with MOL and the union. So thank you to everybody here on the call as well. I think that's it. Thanks, everyone. Oh, actually, it's not it. I apologize. There is one more very important thing, and I had it teed up. COVID is not the only important issue that we're facing. We are facing a number of other important issues, including racism in construction. And we are doing an event on September 28th. And this issue is probably more important than COVID, especially when you look at the long term. And so Amina has worked very hard with the Construction Against Racism Everywhere Committee and our Anti-Racism Committee at RESCON. And we really do strongly encourage everyone to come and participate on September 28th. We are going to recognize the Day of Truth and Reconciliation on September 30th. And this is something that we need to take just as seriously as COVID. And I didn't do a very good job there because I almost forgot it. So I apologize for that. But please participate, share with your network. And recordings of that will be made available as well. With that, I think we're good. Thank you, everyone.